წარმოგიდგენთ ლექციას, რომელიც ვფიქრობ, რომ თითოეული ჩვენგანისთვის ძალიან საინტერესოა, დიაგნოზის და ცუდი ამბის თქმის ხელოვნება. ჩვენი ფონდი დიდი ხანია მუშაობს პალიატიური მზრუნველობის მიმართულებით და ცდილობს განავითაროს პალიატიური და ჰოსპისური მზრუნველობა საქართველოში. პალიატიური მზრუნველობის ერთ-ერთი ძალიან უმნიშვნელოვანესი და შემადგენელი ნაწილია სწორედ ცუდი ამბის მიწოდების ტაქტიკა და მეთოდები, რაც საქართველოში ხშირ შემთხვევაში წარმოადგენს პრობლემას. ბევრი ადამიანისგან ალბათ გსმენიათ, რომ მას ძალიან ცუდი ფორმით უთხრეს შვილის დიაგნოზის შესახებ, ან თავისი დიაგნოზის შესახებ. საქართველოს კანონმდებლობა ამბობს კანონი პაციენტის უფლებების შესახებ, რომ ადამიანს უნდა მივაწოდოთ დიაგნოზი სრულად იმ შემთხვევაში, თუ ამას პაციენტი დაჟინებით მოითხოვს. ნაწილობრივ პაციენტის ინფორმაციის მიწოდება დიაგნოზის შესახებ შესაძლებელია შეიზღუდოს, თუ ინფორმაციის მიმწოდებელი ჩათვლის, რომ ინფორმაციის მიწოდებამ შესაძლოა პაციენტის სიცოცხლეს და ჯანმრთელობას საფრთხე შეუქმნას. დღეს ჩვენი სტუმარი მომხსენებელი არის ქალბატონი ჯოან მარტსონი, რომელიც არის პალიატიური მზრუნველობის ელჩი, მსოფლიო ელჩი და ასევე მას აქვს ძალიან დიდი გამოცდილება ამ სფეროში მუშაობის 28 წლიანი გამოცდილება. იგი თავდაპირველი პროფესიით არის ექთანი, შემდეგ მუშაობდა ბევრ ჰუმანიტარულ მისიებში, არის არაერთი გზამკვლევის და სახელმძღვანელოს და ნაშრომის ავტორი და დღეს ის ჩამოსულია საქართველოში იმისთვის, რომ დაეხმაროს პირველ ბავშვთა ჰოსპისს, რომელსაც ქვია ციცინათელების ქვეყანა და მზად არის, რომ დღეს ჩაატაროს ლექცია დიაგნოზის მიწოდების ხელოვნება. წარმოგიდგენთ პატარა ლექციას და ამის შემდეგ თუ რამე შეკითხვა გექნებათ, რა თქმა უნდა მზად ვართ, რომ გიპასუხოთ.
Thank you so much, Nina. I didn't understand a word of what she said, but I assume it was an introduction to the subject and to myself. And it really is such a pleasure to be here with you. I was here a few years ago when Nina first had her vision of a children's hospice here in Tbilisi. And it has been so exciting to come here and to see that vision become a reality. So thank you, Nina, for the invitation. And my sincere thanks to the Open Society Georgia Foundation. The Open Society Foundation in general has been a leading role player in the development of hospice and palliative care worldwide. And while I come from Africa, I have worked pretty internationally, and wherever you go, you see the logo of the Open Society. So I think that you absolutely have a treasure here in Georgia. So while we're going to be talking today about breaking bad news, the one thing we don't ever want to do really, I thought it was best if we started off with a bit of understanding about what is hospice and what is palliative care and how do they fit together. And then we're going to look at the whole system of breaking bad news from the very important time of preparation through to the activity and then the follow-up. So please, if there's anything that you don't understand, please just stop me. Okay. So what is hospice? Hospice comes from a very ancient Latin word that originally meant a host and a guest. And it comes from the same root in English as hospital, hotel, hospitality. And it really implies a host and a guest. So within a hospice, our patients are our guests, and we treat them the way we would treat any guest. We give them the best that we possibly can. It's for children and adults who have got incurable, progressive conditions. Sometimes the progress is very rapid, and other times the progression is over a number of years. But the reality is it will be the most usual cause of the patient's death. Hospice is also totally holistic in its approach. It cares for the patient and the family's body, mind, and spirit. And it gives the family support from the time that hospice interventions come, right through the period of dying and death, and then into the bereavement period. And the focus is always on providing the best possible quality of life and relieving suffering. And when we talk about the relief of suffering, it is not only pain. It is pain and suffering that's felt by the mind, the pain and suffering that is felt by the spirit. And so to provide palliative care and hospice care, we need to be able to provide a service for the person as a totality. And it can be provided anywhere. Ideally in the patient's own home. That is where most patients want to be. They don't really want to be in hospital. And even though the hospice is second best to the home, for most people they would rather be in their own beds with their own family around them. It recognizes dying is a normal process. We tend to all be very afraid of death and dying, and yet it's something that's going to happen to each one of us, but we don't like to think about it. In hospice we say dying is normal, and what we want to do is help you to live the best you can until you die. And we neither hasten death, and that means we don't do euthanasia or doctor-assisted dying in hospice, but we also don't postpone death, and so we don't let people live longer than their bodies are able to by putting them onto ventilators and artificial life support. And what we do in hospice is we believe there is always something more that can be done. So when the doctors have said there's nothing more that we can do, hospice says yes there is. We cannot cure, but we can comfort. So there is always something more to do, and the goals of care change as the patient's disease progresses. And hospices provide palliative care. So palliative care is the big field of what we do, and hospice is the community response to the provision of palliative care. And I don't know how many of you have been to Firefly World, but it is really beautiful, and I really would advise you to go. It is as beautiful as you would see anywhere in the world, and the quality of the care, the quality of the love and compassion that is given there is amazing. And I really want to congratulate Nina on her dream that has become this very visible reality. But I think this is my favorite definition of hospice. And he talks about hospice for children, but actually it could be relevant for adults and children. And Matty Stepanek was the fourth child in his family to be dying of a rare form of muscular dystrophy. And he was very wise, he was a poet, he was a philosopher, and he said, hospice care no longer means helping children to die well. It means helping children and adults and their families to live well. And then, when the time is certain, to help them die gently. And I think that is beautiful. To live well and to die gently, these are the essence of hospice and palliative care. So you will see that palliative care is very similar when I tell you about the definition. And it's because palliative care developed from the field of hospice care. Hospice and palliative care is the one field that developed from the community into the formal health system. It didn't start the other way around. We didn't have palliative care doctors and then hospice. We had the hospice movement and then palliative care. And again, it's for patients facing life-threatening, life-limiting conditions, serious disabilities, through prevention and relief of suffering. And again, it's caring for the body, the clinical care that we give, the pain and symptom management, the mind and the spirit, and the patient within their social and their cultural context. And contrary to popular belief that palliative care comes in at the end of life and at the end of the illness, it should come in when a diagnosis is made of a life-limiting or a life-threatening condition, so that the palliative care team, the hospice team, can walk that final journey of life together with the child and the family, with the adult and his or her family, or so often with the adult alone. And it requires well-educated and skilled professionals and well-educated and skilled volunteers as well to provide this care. So education is absolutely a foundation stone of hospice and palliative care. Because to effectively relieve pain and symptoms requires knowledge, it requires skill, and then it requires compassion to want to do it and to do it with humanity. And of course, when we're coming to implementing it into an institution, into a country, it requires policy. And any policy that's accepted requires funding to go with it. So there are three things that are important to establish palliative care. The one is a policy, the other is education, and the third is access to the medicines that relieve the pain and symptoms, especially the opioids, and really especially morphine. And this really is just showing you how palliative care can go in and out along the course of disease. It's not necessarily that it comes in and it's there all the time. Sometimes the patient will have palliative care to control their symptoms. Other times they will carry on with their normal treatment. So it goes on, and towards the end of the patient's life, it becomes the predominant form of care. So that when the patient dies, we hope and we work towards a comfortable death, a pain-free death, a death where the patient and the family have accepted the reality of the dying. But more than that, it has been accepted by the World Health Organization through a World Health Assembly resolution in 2014 that called on every country in the world to integrate palliative care into their healthcare system. And every country that is a member of the World Health Organization, which includes Georgia, absolutely agreed to it and signed the resolution. So Georgia has made a commitment to integrate and implement palliative care. But it's also recognized as a human right. The relief of suffering of a child or an adult is recognized in international humanitarian law. In fact, to allow pain and suffering can be equated to torture. And so we need to relieve pain and suffering, and we have the knowledge, we have the skills. But more than that, it's a moral imperative. Why should we leave people to suffer when we have the knowledge, we have the medicines, we have the people who know how to do it, we have the literature that is there to support us, we have the education, and we have the research. People do not have to suffer. And it should be provided wherever the level of care is. So certainly at primary health care level, where most patients will be treated, but also at secondary healthcare level, and hospices often fall into this group where you have more skilled, more professional support, but also at specialist level. And again, it can be provided in the home, in a hospice, in a hospital, in a children's orphanage, in an old age home, wherever the patient is. And absolutely key, and the basis of everything that we do in palliative care, is good communication. So whether we are assessing the patient for pain and symptoms, whether we're doing an emotional or a spiritual assessment, whether we are implementing treatment, communication is what we do. And while many people will say to you, oh, I don't have the skills, I'm not good at communication, I don't know how to talk, it's something that can be learnt. Some people absolutely have it naturally. They do it so well without very much training. Other people are really bad at it. But we do find that if they practice, if they are determined to improve their communication skills, and they work in it, and they do role play, they actually can become very, very good at communication. So if you're doing hospice and palliative care, communication skills in the training curricula is the largest module, and it's the one that everybody has to do. So if you're a doctor, don't think you only do pain and symptoms, you do communication as well. And I think Hippocrates, who of course is the father of medicine, he said it all those centuries ago. He said, I think the best physician is the one who has the providence to tell to the patient, according to his knowledge, the present situation, telling our patients what is happening, what has happened before, and what is going to happen in the future. So what we're talking about isn't new. It's centuries old. It's the basis of very good health care. And we need to remember that when we are working in fields where patients are suffering from serious illness, we're working in a very complex emotional situation. There are lots of emotions. People are at different stages with being angry, with denying that it's happening, with accepting, that being sad. And you as a healthcare worker, you come into this situation and you get faced with it. And especially when we are going to break bad news that they don't want to hear, they really don't want to hear it, you're going to be faced with lots of emotions. And just yesterday, speaking to a young doctor, she said, I don't know why, when I tell them the news, they get angry at me and they get aggressive. But of course they do. You're telling them something they really would rather block their ears to. And we're not only dealing with the patient, we're dealing with the family as well. And the patient might be a child, there might be children in the family, there might be siblings, grandparents, we often forget the grandparents. Anyone who is close to the patient requires help with good communication. And of course, don't forget the people we work with as well, our colleagues who get attached to their patients. Some of our patients we have over a long period of time. We're with them in difficult situations. We get very close to them. And they are also dealing with their emotions in this situation. So I always say, whenever you go into a new phase of a situation, planning is the most important thing you can do. So often I see the doctor gets the results and thinks, I've got to tell the patient right now. No, they don't. They can spend a bit of time planning how they're going to do it. Because bad news is something that the family and the patient don't want to hear. And to be absolutely honest, it's something that we don't want to give either. So we immediately have a barrier. They don't want to hear it. We don't really want to say it. And so because we don't want to tell them, we might pretend that it's not as bad as it is. We might pretend that there are other options. And because the patient and family don't want to hear it, they might not hear everything that they are being told. In most instances, it is the doctor who will be giving the bad news when the diagnosis or the prognosis has changed. But in other situations, it might be the nurse, the psychologist, the social worker who has to inform the child, the adult, the family that the situation has changed. And something that I always say to people, when you are faced with major loss, we know from the research that has been done from the great Elizabeth Kubler-Ross onwards, that when we are faced with a situation of loss, our reaction is grief, and the way that we show our grief is different. We can deny it. We can say, no, it's not happening, it hasn't happened, or it's going to get better. There's going to be a miracle. Something is going to change. You've had the wrong results. It's the wrong person's lab results that you have. But we can actually also get very angry, and that anger can show itself in words, it can show itself in body and facial expression, it can sometimes show itself in physical aggression as well. Because when we tell a patient or a family that the treatment has failed and that there is no other curative treatment, they are faced with multiple losses. The loss of life, of course, is it's the great one. But what about the loss of dreams? You know, the father that says to you, I always wanted to teach my little boy how to play football. The mother who says, I wanted my little girl to be a ballet dancer. So what we're doing when we give the bad news is we're taking away that future. We're taking away the dreams. And we're taking away their hope. Because all along, while they've been having the treatment, while they've been waiting for the lab results, there's always that light. There's always that flicker of hope. And when you give the news, you're turning off the light. And so, of course, they are going to react with grief emotions, and we need to expect it. Not to say, I don't understand why they get so angry. I don't understand why they don't believe what I'm telling them. I don't understand why they got up and walked out. If we go from the beginning and understand that we are giving them the greatest loss that they could possibly ever have thought about, then we will accept that they are going to have a very emotional reaction. Because it has a life-altering effect. Their life has changed now. We've taken away their dreams, but what we've also said is that as you go forward with your life as a couple, as a family, as parents, things are going to change. You're going to be dealing with an illness that is going to progress, with increasing weakness, with changes in medication, with changes in pain and symptom levels, with changes in bodily habits. He may have to wear nappies. He may have to have a commode. He may have to have so many different changes in his life that affect the life you have. You might have to give up your job because you have to go and look after that person that you love. So we're giving them life-altering information. And it takes time to process. And then, of course, we're facing them with death. We said earlier that everybody dies. Sorry, it's something that's going to happen to us. We haven't found any way to stop it yet. As apparently there was a headline in a newspaper once that said, no one will ever get out of this life alive. And so many of us believe in a life after death, but the life we know is this life now. And while we believe in the life after death, we're comfortable where we are. There may also be cultural factors that come into this situation. I come from South Africa, and with a lot of our, especially rural people, they feel they cannot challenge, they cannot ask questions, they cannot argue with somebody in a higher level of situation like a doctor. So the doctor has the status, and if the doctor says this is so, I just have to absorb it and accept it. And so you might have a totally different reaction in that. It's just, well, doctor said so, that's the way it is. So we must be prepared for all of these different kinds of reactions. And we have to be honest when we say to them that the treatment is no longer working, because that is the first really big piece of bad news we're giving them. We have to also accept that we can't say that this is exactly what is going to happen. You know, this time in a month's time, you're not going to be able to get out of bed, your pain will get worse, because we don't know. The prognoses are often fairly uncertain in their time frames. So I know the doctors I work will never, ever give me a time prognosis. They will never say this patient will die in 3 months. Because so many factors come into being to keeping patients alive. Something to live for. Living in good circumstances where you have decent food, where you have access to treatment, where you have stimulation, where you have a family to love you, and you're staying alive for that family as well. So there are many different factors that come into play. So we have to be very careful, Because often one of the questions that gets asked is, how long does he have? How long do I have? When is he going to die? And if you say 3 months, they're counting the days to 3 months, and when the 3 months is up, they're looking at the patient and thinking, well, what's going to happen now? So it's very difficult to give absolute time frames to anything. There are so many different variables. And as I said in the beginning, preparation. Don't think I've got the results, I've got to give the information right now. Take a deep breath. Think about yourself first of all. Live in stressful situations. It might be you're really busy at work. It might be you've got a problem at home. Give yourself time to acknowledge the results, to think about them, to decide when you are going to give this information, how you are going to give it, and who you're going to give it to as well, because it takes time. And check your facts. We've all had situations where a patient or a family has been given the wrong results. So check your facts. Speak to an expert. Speak to someone else. Make sure that you know what you're going to say. And plan what you're going to say and how you're going to say it. I've often had doctors say to me after they've done the course, they practice in front of a mirror so they can look at their face and see what their face looks like. Because we can say good words, but if our face is stern and angry or not connecting, that can say so much to the patient. We need to think about what kind of a reaction. Usually by this time we know a bit about our patients, we know a bit about our families. Is this a family that's very emotional? That the minute you say the treatment is no longer working, the family is going to burst into tears, is going to be crying, is going to be very upset? Is this a father who you know has been aggressive and might become aggressive when you give the results? So think a little bit about the family. What do you expect? And remember, we don't do it in a corridor. We don't do it in a room with lots of other people. If it's in a hospital, in a bed, we're talking to the patient, we draw the curtains. We put the patient somewhere where you have some concept of privacy, because it needs privacy. This is something so important that you're going to say. And remember, if you're going to have 5 people there, have 5 chairs. You don't want someone standing against the wall. You want to have everybody at eye level. So if the patient's in a hospital bed, don't stand over the hospital bed telling the patient the news. Sit down. Get yourself at the same level. We know about that with children. We should remember it's important with adults too. And 2 basic things to have on hand. A glass of water, because they might start hyperventilating, they might feel very faint, and a box of tissues, because they might cry, you might cry. If you're close to your patient, you're close to the family, there might be tears all around. So just make sure you've got those 2 things in place. And review the family situation. Do they have the capacity to understand what you're about to tell them? And that is something that we need to take into account. So there isn't one sort of phrase or one lot of terms or sentences that we use with everyone. If it is someone who has a very simple understanding, you're going to use a very simple way of saying it. The language. Do they speak the same language? Do you need a professional translator? And it's best not to use a family member, no matter how good they are, because they're emotionally involved. And we had a situation where they came to do some filming at a children's hospice that I started 19 years ago. And we had the teacher as the translator for the children while they were filming. And it was only afterwards, when we were listening to the tapes and there was someone who spoke the same language as the children and the translator, who said, but she isn't translating what the children said, because she didn't think what the children said was right. She was translating it in words that she thought we wanted to hear. So be careful with that. Is there support for the family, for the patient afterwards? Are you going to give them this news and leave them on their own? If they don't have a support structure, is there perhaps a psychologist, a social worker, a priest, a pastor, a chaplain who can come in with you or can be there on standby to support this family afterwards? And who should be present? Who do you want to break the news to? It's invariably the close family, but some families want everybody there. Other families in more traditional societies in Africa, they want their tribal chief because he's the major decision maker in their community. So work out, is it the grandmother who's the primary caregiver? Is it an aunt? Work out first. And the principles, we've talked about the eye contact, and keep the eye contact as well. Don't stare at them, but make sure that you are making contact because it allows you also to see how they're reacting, but it also is a symbol of trust. If there are others who are going to be there, like perhaps you're bringing in a specialist who can answer questions that you can't, explain why they're there, give them the introductions. When you are talking to them, don't say it all like this. Not lots of words all together and say, have you got any questions? Which so often happens, and I have seen this. Allow time, pauses, quiet times, times to reflect, times to react. And use short sentences and non-technical language. I'll never forget a patient I had who had very advanced cancer, and his specialist came in and gave him sentence after sentence after sentence after sentence. Basically, what he wanted to tell him was that there was no more treatment that could be given. And at the end of it, the patient looked at him and said, "Doctor, it means I'm going to live, doesn't it?" And the doctor looked at him and said, "Oh, yes." So we have to make sure we're honest, that we're transparent, that we use simple sentences, that we stop at the end of every sentence. Look, have they understood? Is there a question that needs to be asked? Can you see that already they've blanked out, that their mind is all over the place? And you need to just wait for a few minutes for it to sink in. And if you have to repeat it and repeat it until they do understand. But perhaps more important than what we say is the way that we say it. If we use gentleness, if we use kindness, if our facial expression says to them, "I care about this. I don't want to give you this news. I care about you. I want this to be as gentle as possible." Even if you use the wrong words, they'll remember your attitude. So it's our attitude towards them. And that's another reason why it's important not to sit behind a desk. Because if you sit behind a desk and they sit there, what are we doing? It's a power situation, isn't it? Get away from your desk. Go and sit with them so you're sitting all together. And the great Albert Einstein, with all his genius, said, if you can't explain it simply, you don't know it well enough. So make sure you know it well enough so that you can explain it simply. So just for an example, you can ask them, what do you know or understand about your illness? And give them a chance to respond. Then you can give them what we call a warning shot and say, I'm afraid I have some bad news to give you. And then stop and pause. Let them take that in. Don't say, I'm going to give you some bad news and. Would you like me to share the news with you? Because some people don't want to hear it. No, I don't want to hear it. I only want to believe that he's going to get better. Then it's no good giving the bad news. Say, that's fine. Let's talk about this when you're ready. And also say to them, please stop me. If you don't understand, just stop me and we'll go over it again. Then we give the news in short chunks, not all together, as I've said before. It could be something like, you remember that we did those scans last week. Then you wait for them to respond. I've received the results, which I'd like to share with you. Would you like to hear them? Again, wait for them to say yes or no, or often it's not really, but you'd better tell them to me. They show that the treatment is no longer effective. Again, but then what you do is you give them hope, you give them a new goal, and you can say, unfortunately, we don't have any other curative treatment, but we do have other options. We can keep you comfortable. We can control your pain and control your symptoms. We can help you live as well as possible. And give them all reasonable options. Patients and families are looking for every kind of hope of a cure. Those of us who've worked with patients with cancer, with serious illness, know that they go on special diets, they go to special healers, they try all different types of treatment. But it's not for you as the clinician to give them all those treatments. You are there to give them what we feel are reasonable goals to achieve. But also, let's not be too proud. If they say to you, I don't believe you, I don't like these results, I want a second opinion, let them have it. Let them have a third opinion. Because at the end of the day, they have to live with it. We go on to our next patient and our next patient and our next patient. We remember everybody, but they live with this for the rest of their lives, and we need to accept that. So a second opinion, third opinion, fourth opinion. And some of the things that you never say. And we never say to anyone, I know exactly how you feel, because we don't. Everybody feels different. Everyone experiences things differently. You can say my past experience with patients has shown me in this situation that you must be feeling distress at this time. You could say, I can only imagine how upset you must be. Not, I know what you feel. You never do. We never tell them that they've failed treatment, because then we're saying they're guilty. When someone says we failed, it's because we haven't done well enough. We're not a star pupil. What we do say, the treatment no longer seems to be working for you. Something simple. And then we never ever say there is nothing more that we can do. There is always something more that you can do. When we start treatment with most diseases, our aim, our goal is cure. When cure is no longer an option, it doesn't mean we stop having aims and objectives and goals. The goals change as the condition progresses. The goal can be to be pain-free, to have symptoms controlled. A goal could be, I want to go on one more holiday to the sea. A goal could be, I want to be at my daughter's wedding, and the daughter can then bring the wedding forward. So there are lots of things that we can do, but we need to recognize that patients need to have goals, families need to have goals, and those goals give them something to live towards, and they give them hope. And then we can say to them, if we have the hospices, if we have the palliative care professionals, would you like me to refer you to hospice, palliative care? They are experts in pain and symptom management. They know how to deal with a situation. Would you like that? Would you like to discuss it? And again, allow time for questions, allow time for responses. If they're crying, if they're angry, it's no good giving them more information. Wait till they've calmed down. Give them that glass of water. Give them the tissues. Say to them, would you like someone to come and sit with you for a while? Would you like me to come back in half an hour? Acknowledge and allow their emotions. To be angry, to be sad, to say it's not happening. These are normal. The only emotion that we have to be careful about is aggression. Once they become aggressive and they become a danger, then you walk out of the situation until they've calmed down. And some people do behave like that. A fear that they often have when you've been there their health professional for a while through the course of their disease is that they're going to be handed over to someone else, or you're going to say, my treatment is no longer working, I'm going to leave you now, and you're on your own. That's a great fear that they have, that they will be on their own. And so we need to assure them that even though they're not getting radiotherapy anymore, they're not getting another form of treatment or surgery or chemotherapy, but we're still there. We still care about them. We might not be their primary clinicians. They might be going to palliative care. They might be going into a hospice. But they're not going to be abandoned. And even if you hand them to the palliative care physicians, a telephone call, a little note to them to say, thinking about you, how are you doing? These are really important to patients. And then arrange a follow-up. Don't say, I'm going to refer you, and then leave it. Say, I'm going to refer you. You will have the date and the time of your next appointment in the next 3 days, so that they know that something is going to be done. Then make sure that you do it. And if they need a referral to a psychologist, to a social worker, if they need a referral to any other form of therapist, make sure you do that quickly. Because if you don't do it quickly, they'll think, oh well, my treatment's not working anymore, they don't really care about me. What we need to show them is that they are still important. We still really do care. And then just very briefly, a few things about children, because that's the field I work in most of all. And that children are very responsive to hearing news. We often think they don't want to know, or they don't know what's happening, and of course they do. Little children, 2, 3, 4, they can feel when things change. They can understand why they're not getting the same treatment, why they're no longer going to the hospital. We need to give them the information as well. But we need to do it in a way that they understand. So we're never going to use the same kind of language. We're going to use the kind of language that is in line with their developmental stage, that they can understand. And we're going to be honest, because the minute you lie to a child, they know it. And if you lie to a child and say, oh no, you're going to get better, and they can feel themselves getting sicker and sicker, they're not going to trust you again. And trust is so important with children. One of the fun things with working with children is that we have opportunities to do all different kinds of things. We could use puppets, we could draw, we could do music, we can use sand, we can use all kinds of ways of communication. But the most important thing for these children is to know that you care. And that even when you've given them the news, that you're still going to be there, that you're a caring adult, that you are going to be constant in their life. It's not, I'm coming in and I'm going out. Because they have very unique needs, and they need to feel cared for and that they belong. And just some ways that we could use. So drawing, we do a lot of art with our children, and so often they will tell us in the drawings that they do, in the play that they do, in the puppet talk, when you start talking with them with puppets, with toys, they come out with stories that they wouldn't have told you otherwise. So if you're working with children, make sure that you're really good at play and puppets, that you understand their drawings, let them use the ways that they like. Some like to sing, some like to dance. Let them express themselves in their way. So everybody can break bad news. It's not something that only the specialist few can do. Everybody can do it. If you want to do it well, you can do it. And if you're not a naturally good communicator, well, make yourself one. Learn how to do it. Practice. Ask a friend to do role play with you. Talk to the mirror. Talk to a tape recorder. But you can learn the skills. And I've seen people who really, in the beginning, very closed body language, didn't look at people, liked to talk to their papers instead of talking to the patients, actually, with practice, become experts at this. But as I've said in the beginning, when you're doing the practicing, it's part of your planning. And our bishop always used to say to us, if you fail to plan, you plan to fail. So your practice before the time, your learning communication skills is all part of your practice. And then at the end of all of this, while you are reviewing and reflecting on how the patient, how the family have responded, look at yourself. Reflection is very much part of hospice and palliative care. We need to look at ourselves all the time. If they have responded with a lot of anger, is it because that is the way they're feeling it, or might there have been a factor in the way that I spoke to them, that I planned, that I approached them, that actually triggered that anger? And if it's something that you see in yourself, well, work on it. But above all, be gentle with yourself. Because sometimes, no matter how good you are, how expert you are, how much practice that you've had, you can have unexpected reactions. And we need to recognize it's not our fault. We're human. We do the best that we can. And usually it works. And there are sometimes it doesn't work. And that's okay. We need to recognize. And we need to sometimes think, well, maybe I wasn't the right person. Maybe I should have asked the psychologist, the chaplain, the social worker, someone who has a better relationship to be there and to actually be the one who breaks the bad news. And really just to end with words from Dr. Cicely Saunders. Cicely was a remarkable woman. When the war started, the Second World War, she was a student at university. She decided being a university student wasn't much good in the war. So she went and she studied and she became a nurse. And then she hurt her back, as so many nurses do. So she studied further and she became a social worker. And she developed a concept of total pain, which is the pain of the body, mind, and spirit, which is the foundation of hospice and palliative care these days. And when she talked about it, about the use of pain medicines, especially morphine, a doctor said to her, Cicely, if you want doctors to listen to you, you have to become a doctor. So this wonderful woman who had been a nurse, a social worker, studied and became a doctor. And really the core of what she said, and it applies as much to you and to me as it does to the patients. You matter. You matter because you are you. Isn't that beautiful? Doesn't matter who you are, how poor, how rich, how sick, what faith you have, how disabled you are. You matter simply because you are you. And you matter until the last day of your life. And then the core of hospice and palliative care. We will do everything to help you achieve a peaceful death and to live until you die. So with her words, thank you.
I'm Dr. Nino Kartsidadze from Iashvili Children's Central Hospital. ერთ ისტორიას მოვყვები ჩემი გამოცდილებიდან, როდესაც წლინახევრის ბავშვს დაუდგინეთ ნეირობლასტომა და მის დედას ესე იგი შევატყობინეთ ეს ამბავი. და ეტყობა კარგად არ ვიყავი მომზადებული, იმიტომ რომ მან დაიწყო რა თქმა უნდა ტირილი და იმედის თვალებით გვიყურებდა ჩვენ რო ეს და მეც დავიწყე ტირილი. I start crying too. და მივხვდი რომ ეს არ იყო კარგი ჩემი მხრიდან, რაღაც მაკლდა ეტყობა, მე მაინც მომზადება ამისათვის. ეს ერთი და მეორე უკვე ცოტა პროფესიული კითხვა მინდა რომ დავსვა. აი ჩვენ ვიცით რომ თქვათ პალიატიური მზრუნველობა და ძირითადი დიაგნოზის დასვისთანავე უნდა დაიწყოს პალიატიური მზრუნველობა და ეს ორი ერთდროულად მიდის ხოლმე ხანდახან. მიუხედავად იმისა, რომ მკურნალობა ჩავარდნილი, ასე ვთქვათ. მე მაინტერესებს აი ეს ჩემთვის ყოველთვის ეს იყო გაუგებარი, აი მაინც მოცულობა ჰოსპისში გარდა იმისა, რომ ტკივილის მართვა და შემდგომ ეს სხვა სიმპტომების მართვა, აი ძირითადი დაავადებისთვის, თუნდაც იმისთვის, რომ ბავშვმა კარგად უკეთ იგრძნოს თავი რამდენიმე დღით. აი მაგალითად სისხლის ტრანსფუზიას რაც ეხება, თუ აი ეს მოცულობა ჰოსპისში საზღვარი, ვთქვათ, მესმის რომ რეანიმაცია რა თქმა უნდა არ ჩატარდება, მაგრამ აი ეს საზღვრები თუ შეგიძლიათ რომ გითხრათ. Thank you.
Thank you. That's a really good question, and actually in the WHO definition of palliative care for children, it says that it can be given alongside curative treatment. And so yes, if the child has a fairly good prognosis in that they're going to live for a little while, yes, we would do blood transfusions. It depends on the hospice. Our hospice is situated in the grounds of a hospital, so we just do the blood transfusion. But there's nothing wrong with giving them treatment that will relieve their symptoms. So radiotherapy, chemotherapy for reduction of tumours, things like that. If they get an infection, treating the infection. So we can give this potentially life-enhancing and curative treatment alongside hospice and palliative care.
მე ძალიან ბევრი ვაზიარე დღევანდელი შეხვედრის შესახებ და რაღაც მეგონა რომ იმ ექიმებს დავინახავდი ამ დარბაზში, ვინც თავის დროზე მე ძალიან ცუდად მომაწოდა ჩემი შვილის დიაგნოზი, მას აუტიზმი აქვს, მაგრამ არც ერთ ექიმთაგან საქმე ვერ ვხედავ სამწუხაროდ. ანუ, როდესაც დაუსვეს ჩემი შვილის დიაგნოზი, იმდენად ცუდად მითხრა ექიმმა ეს ყველაფერი, რომ ნამის თავი მოვიკარეთ, როდესაც გამოვედი კაბინეტიდან. ამ თემას სტატიაც მიუძღვენი, მაგრამ ეს ექიმი რატომღაც დღესაც აგრძელებს ესეთ მიდგომას მშობლებთან მიმართებაში. მე მაინტერესებს ერთი რამ. აი რა რეგულაციები და მექანიზმები არსებობს აი ესეთი ექიმების, ესე ვთქვათ, ბჭყალებში დასასჯელად, აი როდესაც ექიმი რაღაც თითქოს განზრახ ცდილობს მშობლები აი ესეთ ცუდ მდგომარეობამდე მიიყვანოს, იმიტომ რომ დღესაც გრძელდება სტრესი. ეს არ არის ერთეული ექიმი. საქართველოში რატომღაც არის ეს დღესდღეობით პრობლემა. კიდევ ბევრი ექიმების გამიცი, რომ ძალიან ცუდად ეუბნებიან მშობლებს დიაგნოზის შესახებ. ანუ მე მითხრა თავის დროზე, რომ ჩემი შვილი აუცილებლად სპეცსკოლაში წავიდო და სადღაც 8 წლის ასაკში, 8-9 წლის ასაკში, ჩემი შვილი დღეს დაძის საჯარო სკოლაში, მივიდა თავის დროზე სკოლაში და ძალიან კარგად სწავლობს. უბრალოდ მე მაშინ არაფერი არ ვიცოდი აუტიზმის შესახებ და შესაბამისად კი არ უნდა მოეტყუებინა, სიმართლე უნდა ეთქვა, მაგრამ აი ეს ყველაფერი, რაც თქვენ აქ ელაპარაკეთ, ამ მსგავსი არ ყოფილა და პირიქით ძალიან ცუდად მითხრა. აი უბრალოდ ეს გამოცდილება რომ გითხრათ, იმიტომ რომ ჯანდაცვის სამინისტროს ვეხვეწებით, რომ რაღაც რეგულაციები გაწეროს საქართველოში, რომ აი ექიმები ან დაჯარიმდნენ, ან შესაბამისად რაღაც რეაგირება მოხდეს, რომ სხვა მშობლებს მაინც აღარ მიაყენოს მსგავსი სტრესი. თუ შეგიძლიათ თქვენი გამოცდილება გითხრათ, დიდი მადლობა.
I think what you experienced is something that parents experience all around the world. Doctors in general are not good at breaking bad news. And what we really advocate for, and in every country, is that every doctor should have communication skills as part of their basic training. So if we could only train every doctor, every nurse in basic communication skills, we would perhaps get away with you not suffering the way that you did. I don't know in Georgia, so I don't know the regulations here in Georgia. I guess one could send a complaint to the medical council, or whatever you call it. Is it a medical council here?
No, we don't have it. We have a regulation agency.
A regulation agency. But unfortunately, doctors do tend to get away with it because parents just think, well, that's the way it is.
ანუ რეგულაციები არ არსებობს ქვეყანაში, ანუ კანონი, რომელიც ვთქვათ, ასეთ ექიმებს რაღაც ტიპის ან დაიჭირა, მაგრამ როდესაც ვთქვათ, მშობელი თვითონ კლინიკას, ანუ კლინიკის ხელმძღვანელობასთან დაწერს საჩივარს, ხო? ამაზეც არ ხდება რეაგირება თვითონ კლინიკის ხელმძღვანელობისგან. უფრო მეტიც კი საჩივარსაც კი არ იტოვებენ ხოლმე ხშირ შემთხვევაში სამწუხაროდ ეს პრაქტიკა გვაქვს საქართველოში.
Yeah, I think, as I say, I think that what has happened is that you've experienced really bad communication skills, a doctor who does not know how to break news properly. And it's a very sad indictment of, in fact, the health profession, that we still have doctors and other health professionals who actually don't really respect your basic human rights. To me, it's about respect for another human being. It's about human rights. It's about humanity and treating other people the way you would like to be treated.
So first, Eka Patashvili from Sabin Vaccine Institute from Washington. First of all, thanks Nino and you for this excellent meeting and very important topic for discussion. As a former regulator working at the Ministry of Health of Georgia, I should admit that we still have this problem, and we had this problem of effective communication by not only doctors but nurses and other medical personnel as well. And I remember several cases at the board when patients were complaining mostly on the ways of treatment and communication by doctors rather than treatment and results itself. So obviously this is the real problem. I can share the other experience like we do in vaccination, for example. It's the worldwide practice to have the communication strategies, and this is one of the way of institutionalizing of good practices of communication, and this can be one way to do in Georgia to improve this existing experience. But I wonder, based on your own personal experience, how other countries treat this problem and how they look for the institutionalizing ways of communication.
You know, speaking about a number of countries that I've worked in, they're really fighting now to integrate palliative care as part of undergraduate treatment, undergraduate training of all doctors and nurses, because they recognize that not only the care of patients with life-limiting conditions, but communication skills are totally essential for any good doctor and nurse. And but the only regulation really is around if the family or the patient feels that they have been treated badly, they have recourse to the medical council or to the institutional authority. But I haven't heard of any specific regulation around any punishment for really giving bad information. If you give incorrect information, then you have a case. But if you just do it really badly, it's seldom that you have a case. So we really are fighting for palliative care to be part of the undergraduate training of every doctor, nurse, social worker, psychologist, just to have these basic skills. Because I'm quite often called in, in South Africa we have it in the undergraduate training, we have had it for years. But when I get called in because there's a complex situation, and afterwards the doctor will come and say to me, but how did you handle that? I invariably say, well, actually all I did was listen to what they needed to say, because all you did was talk and you didn't give them a chance. And so they got angry. And so often it's just having the basic communication skills that helps. But we're a long way from having it anywhere in the world, really. It's not just Georgia, I can promise you that.